Welcome back to This Week in Pulmonary and Critical Care Medicine. I'm Dr. Aladdin Sagar, and as always, I'm here to save you the time of flipping through stacks of journals so you can focus on your patients, your families, and maybe even that long overdue coffee break. Remember, what we cover here is for educational purposes only. It's not individual medical advice. Each week, I'll pick a few original papers that I think really matter at the bedside, and then wrap up with one review article you can keep as a reference. So, what's on the table today? We'll start with a randomized trial showing how ultrasound elastography might actually rescue you when pleural cytology comes back negative. Then, we'll unpack the RELIANT trial, robotic bronchoscopy versus electromagnetic navigation. Finally, a real head-to-head test. After that, we'll look at a machine learning model built to predict mortality in ICU asthma patients, which is more common than you think. And we'll finish with a back-to-basics but absolutely crucial review on how to avoid mistakes during right heart catheterization. Let's get into it. Picture this. You've got a patient with a recurrent exudative effusion. Cytology is negative, again, and the pleura looks deceptively smooth and thin on ultrasound. You know the odds of hitting tumor on blind biopsy are low, but you still need tissue. That's where this trial comes in. Researchers randomized over 230 patients to elastography-guided pleural biopsy or conventional ultrasound. Elastography essentially maps stiffness. Malignant pleura tends to be stiffer than benign, and the software color codes it for you, helping you choose the right target. The results weren't subtle. Sensitivity for detecting malignant effusion was 85% with elastography, versus 63% with traditional ultrasound. That's a big jump. And in the toughest subgroup, patients with pleural thickness under 5 millimeters and no nodularity, the difference was even more striking, 80% sensitivity versus just 50%. Safety was a non-issue. Complication rates were low and nearly identical between groups. Now, what does this mean for practice? If you have access to elastography, and let's be honest, many radiology departments and advanced US machines already include it, you should consider using it as part of your pleural biopsy protocol. It's not adding significant time, it's not adding risk, but it's clearly boosting your diagnostic confidence. My take? This is one of those rare small tweak, big gain moments. Yes, we need replication in different settings and cost-effectiveness studies, but if you're often frustrated by thin, smooth pleura, elastography is a game changer. I would adopt it tomorrow. Now let's turn to something that's been buzzing at every interventional pulmonology meeting. Does the robot really beat electromagnetic navigation? The RELIANT trial finally gives us an answer. This was a pragmatic, cluster randomized trial. Patients were allocated by procedure day to either robotic bronchoscopy or electromagnetic navigation. Over 400 patients with peripheral lesions were included. Importantly, diagnostic yield was defined stringently. You had to get tissue that explained the lesion, not just any sample that eventually led to a cancer diagnosis elsewhere. The bottom line? Yield was virtually identical, 78% for robotic, 76% for electromagnetic. Procedure times were a bit longer with the robot, about 5 minutes more, but nothing clinically dramatic. Safety was excellent in both arms, with pneumothorax rates under 2%. So here's the uncomfortable truth. Robotic bronchoscopy, at least on its own, is not inherently superior. If you're running a solid electromagnetic program with access to cone beam CT or digital tomosynthesis, you're not behind the curve. But here's the nuance. Robotic systems might offer better ergonomics, smoother handling, and improved visualization for operators, which could translate into fewer misses in less experienced hands. They also integrate well with advanced imaging platforms. So the decision to buy or expand robotics should be about workflow, team expertise, and long-term strategy, not just raw diagnostic yield. The accompanying editorial by Fuad and Vachani makes a critical point. They argue that the real determinant of success isn't the platform. It's whether you can overcome CT to body divergence with intra-procedural imaging. In other words, you can have the fanciest robot in the world, But if you're not verifying tool-in lesion with cone beam CT or at least fluoroscopy with tomosynthesis, your yield will plateau. They also highlight the elephant in the room. This was a single-center trial with expert operators. In the real world, where experience varies widely, differences between platforms might show up. That's why they call for multi-center studies to reflect everyday practice. Take-home message: focus on your imaging ecosystem. Robots and EMN are tools, but the bigger leap forward comes from confirming your location in real time. Asthma in the ICU is tricky. These patients are rare but high stakes, and we don't have a tailored mortality prediction tool. This study used the massive MIMIC-4 database to build a 12-variable XGBoost model predicting 30-day in-hospital mortality. XGBoost stands for Extreme Gradient Boosting. It's a type of machine learning algorithm that's especially good at structured tabular data, like lab values, vital signs, demographics, things you'd see in an ICU database. The inputs were basic: age, respiratory rate, red cell distribution width, urine output, and anion gap were among the top predictors. Nothing exotic. But the model performed well. Area under the curve of 0.83 internally and 0.80 externally on temporal validation. That's better than general ICU scores like SOFA and OASIS. The authors even created a web tool you can test. Now, this isn't ready to dictate care, but imagine having a quick risk score when you admit a severe asthma case. It could shape monitoring decisions, prompt earlier consideration of ventilatory support, or guide discussions with families. Of course, limitations abound. The data are retrospective, single system, and lack physiologic markers like peak flow or ventilator waveforms. But as a proof of concept, it's strong. My perspective: this is a step toward personalized ICU asthma care. But any center adopting it should validate it locally. If calibration holds, it could become part of daily triage discussions. If not, it at least pushes us toward building smarter, disease-specific ICU tools. Finally, let's revisit a tool we all use, but sometimes misuse: right heart catheterization. This How I Do It review is a must-read. It underscores how easy it is to get wedge pressure wrong. Level your transducer incorrectly, wedge in the wrong zone, or ignore respiratory swings in obese or COPD patients, and suddenly you've misclassified pulmonary hypertension. That can mean putting someone on PAH-specific therapy who shouldn't be on it, or withholding treatment when it's needed. The review walks through the basics: zeroing at the phlebostatic axis, ensuring wedge pressure is truly from zone 3, and averaging across breaths in patients with high intrathoracic pressure. It also provides troubleshooting pearls: how to recognize damping, what to do with arrhythmia-related artifacts, and how to avoid under and over wedging. Why does this matter? Because echo alone is not enough. Right heart cath remains the gold standard, but if you measure it poorly, you do more harm than good. This review arms you with a reproducible, step-by-step approach you can standardize in your lab. My advice: share this with your fellows, print the checklists, and make it part of your quality improvement discussions. It's low cost, high yield, and will prevent misclassification. So, to recap, elastography meaningfully improves pleural biopsy yield in tough cases. Robotic bronchoscopy isn't superior to electromagnetic unless paired with advanced imaging. Machine learning may help us better triage ICU asthma patients. And right heart catheterization only helps if you do it right. That's it for this week's update. If this helped you, share it with your team and let me know which studies you want highlighted in future episodes. I'll see you next week with another set of originals and one review you should keep on your desk. Until next week, keep the vents steady and the nights calm. Take care, everyone.